Hello, my name is Lauren Christopher, and I will be discussing an interdisciplinary recommendation for increasing self-report for suicidal ideation among adolescents. Adolescent suicide is the second leading cause of death in the United States. This is an increasingly important public health issue, for it has become worse in the last decade and has been increasing since 2009. This population has also been identified as a vulnerable population in general for mental health and issues and for suicide among other demographics. As I said earlier, the rate of suicide has increased by 33% since 2009 and is continuing to rise. In 2006 to 2008, in this first graph here, you can see that suicide has begun to surpass homicide and has been increasing. In addition to the 15 to 19 group, you also see the similar effect after 2010. Within this subset, we also see that males and females have differing rates of suicide. However, female suicide among adolescents has begun to rise and is increasingly rising from 2015 to 2019. In fact, it has tripled in the last 5 years. Needless to say, adolescent suicide is a very urgent issue. These are children who are dying and who have no public health campaigns to really turn to that have been successful in bringing about landmark changes in this public health issue. Not only is adolescent suicide a very imperative health problem that needs to be addressed, that has to be through primary or secondary prevention programs, because adolescents are most likely to succeed on their suicide attempt first, on their first attempt. There is no second chance for many of these individuals. As we go through my presentation, I will be discussing what has been done through public health campaigns and experiments that have been conducted in the past, and what from these can we glean and create a better campaign that can help these students. There are a few behaviors associated with adolescent suicide that are very important to mention, which would be anxiety, close relationship with a person who's died by suicide, social isolations, mood swings, depressive symptoms, drug dependence, and lastly, and most importantly, self-report of suicidal ideation. Coming forward and discussing suicidal thoughts has identified individuals who are most likely to commit suicide, but also individuals who are likely to begin discussing changing their behaviors, other behaviors, and potentially reducing the risk of suicide. As we go forward, I will be going through a few different theories that we've discussed in class. The first I wish to mention, and what I think we should be thinking about all these theories within this framework, would be through the ecological model, which was first presented in a public health sphere at the Ottawa Charter in 1986, is adapted from Bronfenbrenner's ecological systems theory. Here we see there are 4 major levels, and then with the 5th of chronosystem. Within these systems are relationships that are related to the behavior of the child and are from its own environment. Within this framework, we can understand that behaviors are not only a creation of the individual, but also a creation of its environment. An environment is something that public health officials can absolutely begin to change. The first type of theories that we'll begin to talk about are value expectancy theories. These theories, the first that we'll be discussing is the theory of reasoned action. Note that added to subjective norms and perceived behavioral control are not only on an individual level, but can also be from other systems, such as through parents and family. Perceiving subjective norms can come from societal and cultural pressures. Within here also, we see perceived behavioral control, which is related to our own control, our self-efficacy concerning our behavior. within this framework, there have been some studies that have been effective at instituting interventions that may have reduced risk for suicide by increasing self-report for suicide ideation. However, it has only been through secondary prevention programs. Through the following study, this paper was able to show that a suicide attempt was prevented among the population that is in this study. The study is made of adolescents aged from 15 to 17 that were taken into the ER after a suicide attempt. They are from a Hispanic and Latino community in a low-income area in the United States. And when they came in, they were randomly selected to be in the control or the experimental group. The experimental group was able to receive a video that primed them to think about suicide and cognitive behavioral therapy in a way that was accessible, and also in a way that allowed them to perceive that they could actually change their behavior. And so the threat of suicide was made very clear. If this happens again, the threat is very high that they will die by suicide. But also the perceived control was heightened. Therefore, they were more likely to make the behavior, which was to keep with the intervention and with the hospital's prescribed cognitive behavioral therapy programs. And they were able to take surveys with these individuals at the 3-month, the 6-month, 12-month, and the 18-month mark. And those in the experimental group showed a higher likelihood of discussing suicide and their thoughts and participating in the intervention. They also scored over time to be less likely to commit, to attempt or commit suicide in their lifetimes. This particular theory will be very helpful as I discuss my own approach to this problem later in the presentation, because when we're identifying at-risk individuals, being able to not only assess, but also to enable perceived control is so important when we're trying to get people into public health interventions nationally and on a larger scale. Using value expectancy models, I think, should be used in tandem with other models that I will be discussing. The second model I'll be discussing is the health belief model. The health belief model is predicted on the basis that behavior change will occur only when sufficient benefits remain after subtracting the costs incurred by performing the behavior. Perceived severity and perceived susceptibility are considered when discussing vulnerability that can lead to the health behavior. There is a cost-benefit analysis, but there's also cues to action from the environment that will lead the individual to engage in the health behavior. O'Connor and colleagues were able to assess a population of adolescents and young adults from 17 in a demographic of 17 to 25. Here we'll only be discussing the adolescent age group, about what in particular would they think would be an individual that is at risk for suicide. And then they were also assessed on their own risk. And like the students had actually predicted, and as the research has predicted, individuals that were most likely to be at risk had very high, very low perceived benefits, very high perceived accessibility, and individuals that were more likely to engage in seeking help and interventions had above average perceived benefits, with also a high perceived accessibility. They also, in general, had a very high health motivation. They also had a very expansive knowledge on the types of resources they had available to them, and what support, and also had support networks that were overwhelmingly positive. All of these things are contributing factors to who will self-report suicidal ideation and then go forward and seek help. The next model I will be discussing is the stages of change model. Here, this is a very different model where we see 5 different stages that the behavior will go, the person's behavior will go through when trying to change their behavior. It is not explaining how the behavior comes about, it's explaining how the person is changing their behavior. And they go through pre-contemplation to contemplation, preparation, action, maintenance. This model in particular is useful when designing an intervention because the individual will be, and their behavioral status will be in this model if the intervention is designed this way. It is not perfect for, it does not always account for relapse and the nature of relapse when it comes to self-reporting suicidal ideation. However, it allows researchers to see where the individual is when it comes to their planning their suicide, when they're thinking about their suicide, when they are planning it, when they have the means, and when they actually are going to have a recent time frame. So not only was it help in research understanding the mindset of suicide, but then it can help researchers discuss what it is, what is an intervention that will allow them to then self-report suicide and then engage in an intervention that's going to lower the likelihood of suicide by increasing their use of cognitive behavioral therapy and vocalizing the suicidal thoughts that they do have. Eggert and colleagues were able to create an intervention in the late 90s that did exactly that. They had designed a 1 semester long course that was given to at-risk individuals in 5 different high schools. They were able to repeat this study 3 times independently for 5 years. And within this group, within the study, they were able to make a primary prevention program that then led to secondary interventions and treatment. The first is that a survey was given out randomly to high school students that allowed individuals to be identified as at risk, but also as gatekeepers, so people who were able to help other students, like teachers and things of that sort, and peers who were supportive. The students engaged in the semester-long class are to be identified as at risk, which followed a strict daily class regimen that taught coping skills and access to treatment and healthy behavior among these students had much lower likelihood of engaging in suicidal behavior because they had increased self-efficacy of staying safe and also and by talking about their suicidal ideation, they were able to work within their intervention. This type of program also is paired oftentimes with social marketing efforts within the school. And as we've seen from other social marketing campaigns, getting the word out to change how society thinks about mental health, suicide, is also a way to promote increased self-report for suicidal ideation and then lower the likelihood of the outcome, which would be suicide. This is why the stages of change model, especially in the Eggert study, is interesting and the most compelling because it reaches all these different levels on the socio-ecological model. It was the most successful, however, has not been repeated since the late 90s. If it were used today, perhaps we would be seeing a lower rate of suicidal teenagers, and also lower rate, as well as the rate of deaths by suicide among adolescents. There is no other study that has worked as well as this has, and if adopted by other schools and even on a national level, it can bring a lot of change because it does reach different levels of the socio-ecological systems theory. Here, as we go through the intervention, we will see how, even though it's within the confines of the stages of change model, it is within the new chapter of public health that we are interested in looking at. Here I have shown how each different part of the health promotion experiment coincides with the socio-ecological model, from the interpersonal and on microsystem level to the macrosystem level. In conjunction with the stages of change model, the theory of planned behavior would be an interesting addition to this health promotion campaign, considering that there is a survey element. At the beginning, if we use the theory of planned behavior during the survey, it would allow individuals to become educated and empowered on not only identifying themselves as being at risk for suicide and then self-reporting, but perhaps becoming the support network for someone else in need, or having the tools to identify it without needing a repeat of this intervention in the future. Because of the nature of that campaign, if of that experiment tied with a theory of planned behavior model, it would allow for a primary secondary prevention program to be created. There are benefits to for both the primary and secondary level of prevention. Both future at-risk students and at-risk students have the tools to succeed when identifying as suicidal due to the presence of suicidal ideation, and can start to begin a conversation where it becomes a socially acceptable topic of discussion when discussing health. In addition, it'll make warning signs a lot easier to identify and understand when asking if a person needs help. From a secondary prevention perspective, those at-risk students not only have a support network of people who will be supporting them through this and identifying it perhaps before they can identify it for themselves, but having these programs in schools through the stage change model will allow information just to be accessible to the student if they're looking for it, and even passively from posters on the wall or pamphlets that's available in the nurses and the guidance counselor office. In addition, if they decide to go through with an intervention, they do not have to go much out of their way to receive the help that they need, for it will be in their school already. This is not a perfect model. There are no such thing as perfect models. Any public health endeavor that tries to address a mental health concern runs into the barrier that mental health is not technically a modifiable behavior. However, self-reporting suicidal ideation is a modifiable behavior. You either self-report it or you do not. And that is where public health professionals need to start becoming creative and looking at these individual behaviors that are part of these bigger mental health problems. In addition to that, even if individuals become more open to talking about suicide and their own suicidal ideation, it does not mean that they will not commit suicide at some point or try to attempt suicide. More research needs to be done in order to prevent more teenage deaths for people who do receive these treatments. There's not enough longitudinal data to really ascertain what was successful in the long run and if the health outcome was ever met. In addition, this is a large-scale program, even in one school, if it wants to be done and adopted across the nation. It's very costly. It is preventative, which is not a priority often when it comes to health campaigns. And there's a very large mental health stigma in the US on all ecological levels. In conclusion, after reviewing this literature on adolescent suicide, I have found that the trans-theoretical model, that in the framework of it being used by Eggert and colleagues, has been the only successful campaign that I have seen. It is not without its limitations. We do not have any impressive longitudinal data past 18 months that can tell us if the health outcome was actually met. But more research has to be done. If tied with the theory of planned behavior, I do think that it would also be more effective going forward. These are my references. If you have any questions, please feel free to email me or talk to me in the discussion. Thank you so much for listening.